This is Ann Sigenhorn coming in from the Emerald Coast of Florida, and I have with me Dr. Scott Ennis. And he's
Thanks for having us.
Well, I appreciate you doing this because we have lots of women who have lots of questions.
Good.
And we want to get some good answers. And I was just so happy to find out that you are doing the proper procedure for explanting.
Yep.
And you're right here local to me.
Yep.
And
nice.
Yes, and not only are you local, he is a world-renowned surgeon. He's known. People fly in to Destin, Florida, just to see Dr. Ennis. And so that makes it even that more special for us. So and not only do you have a location here, you also are in South Florida.
Yeah, we just opened a new location in Boca Raton. We've been in Miami for about 3 years, but we found international flights are much easier between Palm Beach, Fort Lauderdale, and Miami. So yeah, we just opened our new location in Boca this week.
Great. Oh,
so
wow.
We're excited to be in Boca Raton for anybody in South Florida. Or internationally, it's easier to get there.
Great. That is wonderful. One of the ththings that I know that you were really passionate about talking about, I'll get to in just one moment. But for the people who are here and for the ladies who have had some problems with their implants, because that's a lot of my following,
Sure.
is breast implant illness. And with that, I just wanted to find out from you. I noticed that you still do implanting.
Yeah, we do.
And a lot of surgeons do, so I don't hold that against anybody at all. But I wanted the question answered for the audience because
Sure.
some people are going to ask, well, he's still implanting. Why is that?
Sure. So, implants are kind of like food allergies. They're, everybody's body's going to have a different reaction to different chemicals and different substances. Like we've talked about, Ann, there's, if you look at big studies of implants, you compare 100,000 women who have implants, you compare that to 100,000 women who don't have implants, there's not a big difference in the group of people who don't have implants at all when it comes to complaints, aches, pains. However, that's very different than allergies. It's kind of like saying, well, peanuts are safe. Well, there's certainly people that have peanut allergies and can have anaphylaxis reactions to peanuts. So how our body reacts to different substances can be very different. So, I can't blanket statement say that implants are bad. However, I can say that I've seen lots and lots of patients who've had implants who've developed issues and we've taken them out, they've gotten better. So on an individual basis, I think explants can be a very informative thing, and I think can help a lot of people as well. If it's done right, that people understand, the potential causes, the ups, the downs, and the potential risk as well. Because you also have to realize an explant's not always a cosmetic procedure either. The end result of an explant can be very different than a cosmetic procedure too. So we look at explants a little bit different from a health standpoint as well. We look at it as removing the implant and try to make the patient better. Whether it's an allergy, whether it's an autoimmune issue, whether it's an arthritis issue, that's our primary goal in explanting implants. We have to look at the cosmetic outcome of things from doing the implants differently. Obviously, we want a good cosmetic result as well, but it's almost to look at it separately. Our goal in doing an explant is to get the patient better in hopes that their symptoms resolve. Then secondary, we look at, okay, how do we get you a nice result in the implant as well?
Well, that actually was going to be a follow-up question I had, so you kind of just went right into it. Just so people know, this is real live. This is not anything rehearsed. Matter of fact, I only walked in 10 minutes ago, and then we were just trying to figure out where to put the camera, where to put the computer, and how we were going to do this. And Emerald is, she's kind of like your right arm, it seems like. She does everything. And she's back there, and she's monitoring the screen. She's going to come up with questions and see. So if you have a question as we're talking, if it doesn't get answered, then what she'll do is she'll come over and say, hey, she'll just announce to us, hey, here's the question. And try to keep it general, because this is he's not your doctor. He hasn't seen you personally, but you can give a generalized question, and he could answer that for you. So I'm going to start just because one of the things he really wanted to discuss today was the Bloc procedure. And I think that's great because so many women are looking for a doctor who does the proper Bloc.
Yeah.
So what exactly is an Bloc?
So back up a little bit. So when you put an implant in the body, whether it's a pacemaker, knee replacement, breast implant, your body's going to form a scar around the implant. What you want is a nice soft scar that feels like a nice soft breast. Well, some women run into trouble they call a capsular contracture. Well, that's where the scar tissue builds up around the implant. Especially older implants prior to 1992, liquid implants, they were very had a lot of inflammation involved in them. So if the implant would leak, there's a lot of inflammatory response, and these capsules would build up. So long story short, when you do an Bloc resection, you're not just removing the implant, but you're removing that capsule, that scar tissue that forms around the implant at the same time. So in essence, we want to remove the entire implant with all the tissue in Bloc, right, as a whole, remove it all so that you're not spilling or leaking into that silicone in there. So it's called an Bloc resection. Different than doing a capsulectomy, different than just doing implant removal. So if we're just doing implant removal, all we're doing is make an incision, take the implant. Capsulectomy means we've taken that capsule out, but we're not quite as careful about not spilling anything. When we do an in-block resection, we're truly trying to remove that entire implant and all the surrounding tissue all at once. So we almost like delivering an egg out of there without breaking it and spilling the yolk. So that's what a true in-block resection is. We're removing the capsule with scar tissue all at one time.
Great.
I have a question.
Okay.
How long can saline implants under the muscle stay in the body?
How long can saline implants under the muscle stay in the body is the question.
That's a good question. So there's really no longevity or there's no published study that says, okay, implants at a certain time should be removed. So the old implants prior to 1992, and if you look back at the history of implants, the implants prior to 1992 were liquid, so like maple syrup and molasses, and they were kind of a sticky mess. They leaked. So the risk of those leaking would go up after about 10 years. So that, the doctors would tell the implant companies would recommend come in every 10 years and have your implants changed because the risk of them leaking went up. If they leaked, it was a much bigger deal or a much bigger procedure to remove that implant. So we'd encourage the patient to get them removed. In particular with saline implants, it's just salt water. So we don't really have a recommended time that we say, okay, take the implant out at 10 years because worst case scenario, the saline implant, if it leaks, it's going to go flat. Now, the new silicone implants are cohesive gel. So again, the same thing. If they leak, they don't really leak like a liquid like the old ones. It's more like a gummy bear in the sense that it could break. So those implants came out in 1995. They finished the study in 2006, and we re-released them in the United States in 2006. So we've only been using these implants for about 20 years. There are some patients who've had them and they've been in for 20 years. Other people have had them replaced after 5 to 10. So there's really no recommended length of time, especially with saline implants. They say, okay, change them in 10 years because if they leak, it's just saline. Unlike the old silicone implants, anybody that has implants put in prior to 1992, we really did recommend those be removed after 10 years. And certainly people still have them now, we certainly recommend doing them.
Oh, okay. What's your other question? Okay. She's trying to fix the camera. Now, I do have, just because a lot of the viewers that know me, they know that I had saline implants. And these are real. I fluffed majorly. So once mine were removed, what I had found out in research, and so this would be a great time because again, guys, this is unscripted, so he has no clue what I'm about to ask probably. But mine was saline, and I discovered that upon my research that saline, once heated to 77 degrees, is no longer sterile within 2 weeks, and that's why IV bags have to be given. Once the hospital, if they've heated them up at all, they've got to get rid of them. So they usually donate them to like a paramedic school or EMT school. So when I found that out, I was very disheartening because I'm a former plastic surgeon scrub tech, and I had no knowledge of that. And so, what is your opinion of that?
Well, any item that's sterile always has a limited shelf life. Yeah, I've not heard that story myself, but it certainly makes sense because if you break that sterile barrier, then there's mold spores in the air, there's bacterial spores in the air, and anything that gets on that barrier can contaminate that. Now, once it's inside the body, it's a sterile environment in there, and it shouldn't matter it's in the body, but it's the transfer of that fluid from that IV bag into the implant. Now, most plastics use what they call a closed system, where it's actually just like an IV tube, and it's inserted in the bag and inserted in the implant. So that saline is never exposed to air, which what you don't want to have happen is for that saline to be poured in a bowl where it's open to the air. In theory, things floating around the air could land in that bowl, get sucked up in the syringe, and then squirted into the implant, because that's where you could get it contaminated. So if people are looking at saline implants, then the closed system is certainly the preferred method of filling those implants. But you have to worry about, the sterile packaging, how long it's been sitting on the shelf, how long has the IV fluid been in the warmer, because they do typically keep IV fluid in the warmer, so they're not putting cold IV fluid into the patient during surgery.
Okay. So, okay.
Next question is, Dr. Ennis, what's your opinion on removing a saline implant by puncturing the shell valve while still on the patient and using a suction tube to drain it prior to removing from the pocket?
I think the question is, can they, should you remove the saline before moving it to the implant? Again, I think it depends on the method it's removed. If it's a closed system where you're not leaking that saline into the pocket, then I think it's probably okay. Everything we do, and it goes back to the in-block resection question, is these things are really not as much of a cosmetic procedure, because if you think about, if I have to deliver we'll say an egg, but let's say it's an egg the size of a softball out through an incision this big, it's almost impossible not to break that implant or deflate that implant. However, if I make an incision this big, I can get it all out of there without breaking it. So if somebody's more concerned about the size of the incision, that falls into the cosmetic category. Well, we may say, okay, we're going to deflate that implant inside so we can get out the little tiny incision. Or we're going to, we're not worried about the contamination issue, so we're going to break this implant, take it out piece by piece, take out the capsule piece by piece. Whereas if it's an in-block resection, we're worried that we don't want to spill that saline, we don't want to spill that silicone in there. Then I've got to have bigger access, or in essence, a bigger incision to get into that space to take that, now the softball out without breaking it. So that's what my analogy about is this a cosmetic procedure, or is it falls more in the reconstructive category, or the health, you're worried more about health. Because, if you're worried about the implant causing a problem, we probably don't mind a little bit bigger incision in order to get that implant out of it.
And that's what I was going to reiterate was, if you truly believe it's your implants making you sick, then I personally feel that a woman's going to be like, just take it out the safest way it can come out. So a little larger incision, don't worry about that. You can fix that later.
Yep.
If that's your concern. Yeah.
Scars fade very nicely. And you have to remember the way a scar fades. A lot of people look at, they post out pictures on the internet, and they look at, say, a breast lift or a breast implant incision. Most of those pictures are done at 3 months after surgery. In the natural healing process of the scar is going to be a little fine line when you first take the dressings off. And then over the first 3 months, it gets bright pink. That's the inflammatory response the body goes through as it heals that scar, and the fibroblasts are laying down collagen. So when you see those pictures, especially when a flash goes off on them, the scars look bright pink at 3 months. Now, keep in mind, that's not what the scar is going to look like. It takes a full year for that scar to fade away. Fast forward a year from the surgery, it's going to be a little fine line of the scar. So when you're talking about a lift or an implant incision, don't worry about the scar looking pink in the pictures, because those pictures that you see on most plastic surgery websites are at 3 months when the scar is still very pink.
Okay. Do you have another question? I'm going to let her do another question while I have to do one thing to the phone. Go ahead.
With saline implants placed under the muscle, if ripples start to form under the breast, is this reason for concern?
No, implants, especially saline implants, are really prone to rippling. So if you look at the anatomy of the breast and the muscle comes down and stops about the level of the nipple. So in everybody, the bottom third of the breast and the bottom third of the implant is not covered by the muscle. So in almost everybody, they can feel an implant right along the bottom. Even with a silicone implant, you can feel it. But in particular, with a saline implant, you can really feel it kind of scalloping or rippling. So rippling is determined on two things. One is the type of implant, the size of implant, the position of the implant, and I say two things, it's more than that, and the amount of breast tissue someone is starting with. So somebody that's very flat chested that doesn't have much breast tissue, they're almost always going to get a little rippling, especially with a saline implant. So the way we minimize the rippling is twofold. We put them under the muscle, and then the new silicones are much less likely to ripple than saline. And then the amount of breast tissue, the less breast tissue the patient has, the more likely they are to ripple as well.
Going back to Bloc, one of the questions would be, if I was a patient coming in to see him, maybe, am I a candidate for the Bloc excision of my breast implants, and what can I expect while I'm at the consultation?
Sure. Actually, it brings up, we had a question that came in earlier. One lady said that she didn't have enough tissue to have an in-block resection. So you think about it, you got to take this implant out, and it's almost like an orange peel. I need to go in there and take this orange peel out around the implant as well. So if somebody has a really thin, really narrow, about a small amount of breast tissue around the implant, then a true in-block resection may not be possible, because there's just physically not enough tissue to get between the skin and the implant there. So in those cases, we do what we call a partial capsulectomy. We take out all the capsules that we can safely take out without worrying about blood supply to the skin, having the skin die or the nipples die. So in those cases, we do a partial capsulectomy, and then we ablate the rest of the capsule. So we have a cautery device in surgery that we use. It's an electric device that we can actually paint and kill all those cells that have been in contact with the implant. So in a case where somebody's not a true candidate for an in-block resection because their skin's too thin or their tissues are too thin, then our backup plan is we're going to ablate it and we can't get out of there. So it kills those cells that have been in contact with the implant.
And I get that question quite a bit, ladies, is it has to be Bloc, it has to be Bloc. And being a former plastic surgeon scrub tech, again, I would say, well, did the doctor cauterize what was left? Because if you cauterize what was left, it's dead tissue, and your body can, over time, dispose of it. It detoxes it, because our bodies naturally will do detoxing. Next question is, oh, this one's real important. This is a hot topic right now, fat grafting. what is your opinion, and do you do it, and what all is involved?
Yeah, so even if you look at the whole topic, fat grafting is a really hot topic in plastic surgery right now. And it really gained fame with this Brazilian butt lift procedure. And a Brazilian butt lift is really a misnamed procedure. What we're doing is we're fat grafting the butt. We're taking fat from other places, we're putting it into the butt. Now, unfortunately, there's been some problems in South Florida. There's been some deaths from fat grafting because it wasn't done properly. They were injecting fat deep into the muscles, trying to get as much fat as they can. They were actually injecting into some of the blood vessels, and people were getting fat emboli from it. So anytime you do fat grafting, whether it's the butt, the breast, you really got to make sure you go to somebody who knows what they're doing, because it's not, you're taking essentially dead fat cells that you've harvested in place and putting them back in the body and expecting to live. Now, the trouble that you can get into, or the caveat, or I guess the pitfall you would say with breast, is you can't just take an implant out and fill that space back up with fat, because there's no blood supply. So if I take an implant out and just fill that cavity with dead fat cells, they're going to die and they're going to corrode and become infected, and it's a big deal. So what we have to do is we have to put the fat cells back into the living tissue. So depending on where somebody's starting, it depends on whether or not they're a candidate for fat grafting. First of all, you got to have fat. If somebody that's really thin doesn't have any fat on them, they don't have any fat to get to borrow. Second of all, those same patients tend to be the same ones that have small breasts, that can be flat-chested, and we've got to have a place to put the fat. So if their breast tissue is only this thin, I've got a very limited amount of space. I can go back in there and put that fat back in. But depending on the patient, sometimes we can take the implant out, do an in-block resection, and then put some fat back in there. More often, though, from a safety standpoint, what we do is we address the initial problem. Let's get the implant out, and before we add to the variables and complicate the issue, let's let everything heal. Let's see how you feel. Then wait about 6 months, let everything heal, and say, okay, now let's go back and add a little fat in the top part of the breast. Try to fill in that top part, get a little better upper piriformis, and reshape the breast at that point. If you're trying to take the implant out and put fat back in at the same time, you don't always have a lot of control over the shape of the breast, where we're putting fat, how much fat's going to live, what's going to happen to the scar tissue where the implant came out. So we have to be kind of careful about that. And so one you want to get as good a result as you can from the in-block resection, because you want to fix those problems. Secondarily, you want to replace that volume back with fat. And the things you got to look at there is, one is you got to have fat to put in there. You got to have fat, a place to put the fat, and you got to have fat to harvest.
Okay. And when you're doing the fat grafting, because I've heard fat grafting with stem cells, do you do that?
Yeah, so it's interesting. The adult stem cell is really a type of fibroblast. And fibroblasts live in the fat cells. And the way the body uses those, if you have an injury, say you cut yourself, that fibroblast is going to migrate from one place to that cut, and that fibroblast is going to start making collagen fibers, and it's going to start working to fill that and to heal that injury. So a fibroblast is an interesting cell because it can do a lot of different things. It can modify itself and to help the nerve heal, it can help the skin heal, help the bone heal. So when we take fat cells out, the fat cells are full of these fibroblasts, which are a relative type of adult stem cell. So when we're taking fat cells out, we're putting those fat cells back, and we are transferring these fibroblasts, or in essence, an adult stem cell in there.
Okay, great.
2 questions. Okay. The first one is, what is the shelf life of a saline implant?
So the question is, what's the shelf life of a saline implant? Like we talked about earlier, I assume what you're asking is how long that implant can be in the body. We say 10 years. 10 years came about when we talked about earlier, and with the silicone, the old silicone implants, the risk of them leaking was higher. We like to get those implants out after 10 or 15 years, because especially the saline implants, that rupture risk goes way up, especially after 15 years. And if there's some concern that Anna and I talked about earlier, some concern about what's in that saline, what's the closed system that put the saline in, is there something inside that implant I don't want in my body, then ideally we like to get that implant out before it leaks, so before the valve starts leaking, which I think, and you said you had a problem with yours. And the way that valve works, it's a 2-valve system, and it looks a little bit like the valve on a soccer ball or a football, where you fill that and when you pull it out, it closes. But that valve is a little flat valve that becomes incompetent. Whatever saline's in there can come back out that valve as well. So, long story short, you want to get them out before they rupture. 10 to 15 years is probably reasonable.
Okay, so 10 to 15 years, which is a lot of the numbers that we are hearing from many doctors. So that's being very consistent. And again, so with y'all asking questions and me looking at a paper and stuff, he does not know what I'm asking. So I'm throwing them at him and he's answering. So, all right. Do you One other question? Okay.
What symptoms or signs of implant intolerance or sickness, and can you have it with silicone implants too?
And you want to answer that one? That's probably much more versed in that than I am. I'm gonna let Ann answer that question.
So yeah, he's been so good. He's seen a lot of the ladies that I've sent over, and so there is a list. We have a list of, and the thing about that is, if you look at the list separately, you might not think anything to it. I'm a former plastic surgeon scrub tech. I did not ever once think it was my breast implants. It wasn't until one ruptured, and a doctor said to me, "Oh, well, did you know that this is why," and then told me what they were made of. That's what threw me. So my body reacted. I started out not knowing this, but I had these headaches that wouldn't go away. Had MRI, CAT scans, everything. They couldn't find anything wrong. The medicine they gave me did not work, and I did not have migraines. It was just this low-lying headache. So that was one of my personal symptoms. I started developing ovarian cysts. I started miscarrying. I had sores on my face, which in high school I had beautiful skin. Everybody hated me because how pretty my skin was. I had dry skin. So dry skin typically doesn't break out. But I had awful, the scars of acne that happened as an adult with breast implants in me, not knowing it was them. The doctors kept treating with antibiotics. They kept treating with topical, everything. I had vision problems. I started gaining weight, but I didn't start gaining weight until the implants had been in a certain amount of time. And that's why, one of the reasons why I never, ever suspected it was my breast implants. So gaining weight, vision problems, a headache. My joints started getting sore. I started having sinus infections repeatedly, like 4 or 5 a year, instead of just once, like during flu season. I was getting them continuously. Never had allergies before, developed severe allergies to different things such as latex, food, watermelon, bananas. I've just learned avocado, but that goes hand in hand with a latex allergy, so I've been told. Things like that. And then sores started coming out on my legs and my arms. I have scars where just little granules would come out of my skin. That kind of stuff. And so some people get vertigo. So whereas I had vision problems, it seems like you don't have vision and vertigo. Some women will have one or the other, tinnitus or something like that. It's either their ears or their vision. But I haven't. If anybody else has had both, let us know. But we do have a list. We have a list of things that you can look at. I was actually diagnosed with several autoimmune illnesses, which since my explant, now my tests are negative. So I was being told I had rheumatoid arthritis. I was told I had lupus. I was told I had MS. I had all these things being told to me. And when we got explanted, not immediately, it took several years, but here I am 4.5 years later, and just last year, all my tests are negative, whereas they've been positive the whole time. So I had some infections just because my saline, I did have a manufacturer faulty valve, and it leaked in my body. You can see stuff spraying in, spraying out, and it was caught for years on film that no radiologist ever told me. Once it's amazing to look at my radiographs because you can see it spraying, you can see it sucking in, you can see something growing, and I just wish we knew back then, but it's not. So here we are. We're just giving information, and we want to help other people. And Dr. Ennis has gotten on board with you know what? Some of these women are sick. They generally are sick, and he takes the implants out. And he's watching them get better, and he's like, this for certain people, it is real. And
yeah, I think you're right, Ann. It's a negative. There's no one sign that you say, okay, I've got my big toe hurts, and that's got to be my implant. It's usually a nebulous group of symptoms that people have, and they've exhausted all the other research. They've been through this, they've been through all the testing. Nobody can really seem to find what this cause is. So we use this a little bit as a salvage procedure, and I tell patients, when you come in and you ask me, is this going to fix my vertigo? Is this going to fix my vision? Is this going to fix my rashes? I don't know. And that's an honest answer, because I don't know what's causing these things. But we do know that you, in particular, you've been through all the testing. You've been tested for this. They've tried those other things that haven't worked. Let's take them out and see. And it's been interesting that a significant portion of them do get better. Now, I'll also tell you that some of them come back and say, you know what, it didn't make any difference. I missed my implants. I'd like to put them back in. But at least we know. We've taken out that potential antigen. We're taking out that potential factor that could be causing those things. And we give it time. It's not an overnight thing. Your immune system's not going to calm down from that overnight. It takes months to years for all those antigens, like you mentioned yourself, to go away. We see people sometimes in a week or two to get better, but we also see them where 6 months, a year goes by before they really feel like that they've gotten better. So if the patients are thinking about this, like I've been through all these other things, but really I'm at my wit's end, I don't know what to do. And you want to say you're going to take the implant, you got to give it at least a year for everything to calm down, let your body calm down. That antigen's now gone. You're no longer exposed to that allergen or whatever it is in that implant that's causing these issues. And it takes the body a while to calm down, especially if it's been there for a long time.
And that's an important point, because some people expect you to get better overnight. I've heard doctors say that to women. Well, you took your implant out, you should be better. Well, no, he just brought it up. That's not the case. It takes time. So that's real important. So, and that's one of the reasons why I just fell in love with him and his wife. They've just been really receptive to the community here and trying to make sure that we had a local place for women to have their implants removed. We have another surgeon in the area. We have surgeons all over the place that have been just a delight to work with and help, and we appreciate it. So I do appreciate you doing this.
Sure.
One of the things I know that I want to ask is, some of the women come in, and we kind of touched on it, but I'm going to just point blank ask it. They come in, they get their implants removed, and they have this fold of this, like they have this line that all of a sudden is sitting here, and usually it's from the nipple back, and whether they're flat chested or not, it doesn't matter, but they have this line. What exactly causes that? Is it when you're removing it, or is it when it's being put in? We've heard several answers.
The natural fold of the breast. So most women who have breast implants have breast implants because they have small breasts. And so you think about, say their natural breast is this big around. You're putting an implant that's this big around. So the implant that you put in there is bigger in diameter than natural breast tissue. So that over time, now you've had implants for a couple of years, that skin's been stretched out. So when you take the implant, everything shrinks back down, but we have this fold of skin down here that's been overstretched essentially from the implant. It's called a double bubble or a persistent fold, the two terms you'll hear. So it's a pretty easy process to go back and fix. And what you have to do is go back and tuck that fold back under. So you're recreating that natural fold of the breast tissue. And if you look at our website, there's a couple of examples of correction of a double bubble deformity. It can actually happen if somebody still has implants in as well. But that fold that you're talking about is actually their old fold from the breast tissue. That's the fold of their native breast. And then you're seeing the fold below that, which is the artificial fold that was created by the implant. So you fix it by tucking the artificial fold back in and recreating the natural fold of the breast.
Okay, so just because I know how some of the women think when we talk, when it's doing a line and a fold and it's like right at the nipple back, did they just have low sitting nipples, or they were that flat?
Gotcha. Okay, so there's a second thing that can happen too. You can also get a little tethering of the muscle. We typically like to put implants under the muscle because when they're under the muscle, they're softer. The capsular contracture risks are less. Mammograms are much better when the implant's on the muscle and the muscle supports it. But when you do that, so if the breast is like this, here's the muscle, and the muscle sits here. So the muscle connects in just behind the nipple there. So if there's some tethering of where that muscle connected to the implant, or they get a little scar tissue on there, that's the second thing that can cause that. That muscle can pull. So when the implant's no longer there, that muscle's now pulling in. They'll get a little persistent fold there. Sometimes women that had implants put in around the nipple originally, they can get some tethering of that scar, and the nipple can cave in a little bit. That's another reason it can happen. So there can be different reasons. You get the double bubble, which is a persistent fold. You get some tethering of the muscle, or they can get some tethering of the old scar tissue from either the capsule or where the implant was put in.
Is it the same thing to fix it?
Not really. It's
okay.
So to fix the muscle tethering, you actually want to release the muscle off the skin. So you separate the muscle so it can slide freely, because the skin and the muscles have a natural tissue plane around them where the tissue plane stretches and slides. So if that's tethered, every time that muscle pulls, it'll create a tethering or an animation deformity, is what they call it there. And that's fixed by releasing the scar tissue where the muscle connects to the skin. The scar around the nipple is one of the more actually difficult ones to fix because that's tethered. That nipple scar is tethered to the capsule. But you fix that by releasing the scar tissue and sometimes doing some fat grafting to put some spacer or some fat back in between there, so there's a space between the nipple and the whole capsule to allow that tissue or that skin to slide normally.
And is that considered, when it's something like that, just on a cosmetic level? Or would it be a medically necessary?
It's always hard to say. Okay. It's always hard to say. And every insurance company is different. I always say insurance companies love to take your money, but they hate to give it back. So it's really a very individual thing depending on your insurance company. And certainly you can write it up as tethering, you can write it up as some animation deformities, things like that. And they wish they could call their insurance company and see if they qualify for having help.
Okay.
And some of those things can be easy to fix in the clinic and some require surgery.
Okay.
Dr. Ennis, what changes, if any, have you made to the information that you give a patient during the consultation?
So you have to, there's an informed consent process that everybody has to understand, especially young patients that come in and they want implants. Most of them are not thinking about the long-term effects of it. So a lot of them you have to really sit down and explain not only the the cosmetic outcome, but the downside too. And there's risks, not only short-term risk. You've got the risk of hematomas, you have the risk of capsular contractures, you got the risk of malposition where an implant doesn't drop. But you've also got the long-term risk. What happens 10 years down the road? What happens if that implant leaks? And how do I fix it? What's the financial aspect of it? And it's something I think that all patients ought to ask if they're considering implants for the first time. That, what's it going to cost me to get something fixed if it is a problem? Most surgeons should tell you that they're not going to charge you for it. There may be some anesthesia facility costs to it. But to answer the question, I think that the biggest thing, and the implant companies have actually done a good job now, I think, in providing a lot of this information on their websites and through the FDA on implant risk as well.
One more question. Can chemotherapy affect saline or silicone implants?
I don't know an official answer to that question, but I would assume not. Radiation certainly can. Chemotherapy is typically targeted at cell growth, and since the implant's not a living object, it's an inanimate object sitting there it shouldn't, radiation will affect an implant not as much with the implant itself, it affects the scar tissue around the implant. It causes that scar tissue to really tighten down. So if they have implants that get radiation, oftentimes they get it with pretty significant contractures afterwards. And those can be very hard to fix because if you try to fix them, they just come right back with the radiation.
That was really a good question. All right, so we did went over most of the end block information. That was the end block and the fat transfer was stuff that I was really wanting to make sure that we did get covered today. I mean, I could probably ask questions all day long, but I know you don't have time for that. So if anybody else has any other questions that you want brought up now, as I walked in, we were talking about how many questions I probably could ask. And also afterwards, people who catch this later may have some questions. So there's a chance that we'll do this again.
You always feel free to email us through their website.
There you go. So they have a website.
It's nsmd.com is our website here in the Panhandle, and Boca Plastic Surgery, BOCAplasticsurgery.com is the South Florida website. You can contact us through either one of those. Just send information, send a contact to us with questions, and we'll certainly try to give an answer.
And I'll have Emerald, if you'll type that in, so that if you put it in the comment section, and then when I get to my phone, we'll put it in my comment section as well. That way people can have a clickable link so that they can learn more. I think those were the main questions today. I know fat grafting was really a huge topic that we wanted to cover. And then, of course, the end block. We always want to talk about end block and why we feel that that's important. And I'm so thankful that you're doing that and I'm able to have that done. You don't take insurance at all.
We don't. No.
Okay. So they don't take insurance at all. Some offices do, some don't. And you always just have to contact your carrier to find out what they do cover. But usually there's 4 reasons to have your insurance pay for explant. So I'll just give you a little tip now. It is, if you have cancer, they will usually, because now there's a couple of insurance, and I can't say a name of an insurance company because my plan, we may have the same insurance company, my plan's different than his plan. Therefore, my plan may say explant is never covered. His plan may say, if you have cancer, it's covered. If you have a rupture, it's covered. If you have a capsular contracture of 3 or 4, it's covered. And if you have pain in your breast, it's covered. Usually, I would say 75 to 80% of the companies cover those 4 things. Every time you're going to have that small group, that small individual plan that's going to say something different. But for the most part, if you have one of those 4 things, it is usually a covered procedure. So I do want to let you know that. And we always
I think the other word too, especially when it's breast cancer patients, symmetry is a big word.
Yes.
They're required to cover the opposite breast. Used to be they would only cover the breast that had cancer. Now they're actually required to cover the opposite breast for symmetry. So symmetry is another buzzword that the insurance companies, not they like to see, but they have to cover symmetry. So asymmetry is a big issue. So make sure that they're documenting the asymmetries are there, or that the opposite breast is being done for symmetry.
I know one of the other questions that I typically ask when I call an office. So I'm going to throw those at you just because those are my normals. My normal is, when you take the implants out, of course we asked about insurance. So insurance, we already covered that. You do the end block. Do you put drains in?
It depends on the patient. We try not to because it's a portal for potential infection to get back into that space. So depending on the patient, if there's been some bleeding, if there's worry about infection, if there's a lot of ruptured, it's called extravasation of silicone, which sometimes will. But for the most part, we try not to.
Okay. And what pathology do you send off for? And do you, because you're a freestanding clinic, you don't have to send where the hospitals do.
Right.
Do you send, and if so, what do you usually send?
That's kind of up to the patient because we don't do insurance. That potentially is if the patient does have insurance, and that's an extra bill. We're always happy to send the implants out. Now you have to specifically specify what you want the pathologist to look for, because if you just send them an implant and say, "Yep, it's an implant," and throw it in garbage.
Okay.
So you always have to be careful and make sure that your surgeon, if you want the pathologist sent, to specify what you want it sent for, whether it's cultures or mold cultures or anything like that. You can make sure they specify what they're doing, because if they send it with gross, they'll just look at it and say, yes, it's an implant, and start it.
Okay. So you would, if I came in and asked you, so I would like to see if there's any bacterial infections or anything like that, to see if I need to be treated, but I also want to be tested for ALCL.
Mm-hmm. Yes, and so you certainly can. And for ALCL is a new lymphoma that they found. Now, the vast majority of those cases have been associated with textured implants, not smooth implants. So, I had a lot of patients call, they have smooth implants. I've heard about this new lymphoma that's out there. There's only been a few hundred cases of it documented, almost all with textured implants. So it usually occurs with fluid collection. So if there's an unusual fluid collection on the implant, then we'll send some of that fluid off to the pathologist to have them tested.
Okay. And all right, so we went over drains, went over ALCL testing, pathology testing, end block, fat grafting stem cells, any kind of complication.
I think the big picture is, it's a very individual thing. So like we talked about earlier, and if you look at big studies, and we do a lot of first-time implants, and I have to tell the girls the same thing when they ask me, are implants safe? Well, if you look at big studies with big groups of women, yes, there's no increased risk of problems. But the same analogy we used earlier, it's kind of like saying peanuts are safe or peanuts are not safe. There's certainly people that have peanut allergies that can be a devastating, life-threatening problem if they come in contact with peanuts. So it's sort of the same thing with implants. It's a very individual thing, and so if somebody comes in and they look and say, okay, I'm really concerned my implants are causing all these problems. Well, we have to be honest, we don't know. But let's do an in-block resection. Let's take it out. Let's give your body time to heal and see. So it's hard to look at studies, and it's hard to look at big groups of people to say that, okay, all these people had this problem, all these people didn't have this problem, because it's such an individual reaction, how the immune system reacts to whatever the pathogen is that's in that implant, whether it was a contamination, whether it was the silicone shell itself, or some metals or some micro contaminants that are in there. So each person is going to react very differently. So it's a very individual conversation you have to have with everybody. So when somebody comes in, we have to answer the question, we don't know if it's going to help, but let's try it and see, because I think it's a significant number of people that does help.
Great. And is there anything that you wanted to touch base on pertaining to any of the breast surgery?
I don't think so. I think that if somebody is looking at getting an explant done, you need to look at, one do they do is a true end blocker, they just do a capsulectomy. Eventually they'll just remove the implant, because if it is a true pathogen that's causing a problem, you want to remove everything that's there. Mm-hmm. Keeping in mind, it's not always a cosmetic procedure. Our primary goal is to get that implant out, get whatever's in there out. The cosmetic part of it becomes a little bit secondary. So let's get it fixed, let's get you feeling better, and then we come back and talk about things like breast lifts and breast lifts and fat grafting and things like that. Because some of those procedures need to be done secondarily for safety reasons.
Do you ever do an en bloc with a lift after?
Yeah, you certainly can. Okay. But it depends on the patient. So they've got to have some tissue there. If they've got a fairly large breast and they've got some tissue to work with, then yes, you can. If somebody has very thin tissue, then you can't. So like we talked about earlier with the fat grafting, is I've got to have some place to put that fat. So when I take that and do an explant, do an en bloc resection, they've got to have some place to put the fat back. So if they have very thin tissues, then they can't really lift and they can't do the fat grafting at the same time. If somebody's got thicker tissues, they've got a fair amount of breast tissue or soft tissues and blood supply to work with. So again, that's another one that you've got to see your surgeon and talk about safety as much as anything.
Yeah, because that's the biggest concern. We want you safe. We want you doing okay. And again, he's got women who come from around the world to see him.
And be careful too, because you can find a surgeon that will always say yes. Because it comes, if you're willing to pay them, they will do it for you. But be careful, because you really need to listen to the one that says, let's do it safely and let's do it in 2 steps. Because a breast lift in particular can be a very precarious surgery, because you're changing the blood supply to the skin, you're changing the blood supply to the nipple, and there's a significant chance if you do too much, if you do an en-bloc resection, there's a lot of scar tissue, a lot of silicone that's leaked out, and then you change the blood supply, and now you're going to try to lift. You have a significant risk of having nipples die, having bad scars, having problems during needle vision. Anyway, so a lot of the better surgeons are going to tell you, let's stop, let's do the first thing first, let's make it safe, let it all heal, then we'll come back and do the lift with the back. So don't go doctor shopping for somebody who just will tell you yes, they can do it because they want to do it at the same time, because you'll always find somebody that will. But the conservative approach in the right person is to do it in 2 steps. But we do it at the same time too, so it's a very individual thing. Just caution people about trying to doctor shop to find something. Well, I don't want to take I have to have 2 times off. I want to have 2 recoveries. I want to have 2 surgeries. If the doctor tells you it's not safe to do it, there's a good reason to tell you that. So you be careful about shopping for somebody who will. If you've got a couple of surgeons already told you they won't.
A couple questions.
Okay.
Your opinion on antibiotics after explant surgery?
Yeah, it depends. We use, in almost all surgery, we use antibiotics through the IV. Most of the studies show that a single dose of antibiotics through your IV minimizes your risk of infection. You don't need post-operative antibiotics because it actually begins to kill the normal bacteria. Now, if there's anything in the breast cavity that we're concerned about, then yes, we would certainly use antibiotics in that situation.
Okay.
One more. Are capsules dangerous if left?
It depends on the etiology, because all a capsule really is just a scar that formed around that implant. So if there's a concern about an autoimmune problem or a disease, some other symptom that you're having, then we'd like to get that capsule out. But if the patient comes in and says, I just don't want my implants anymore, they're too big, I'm kind of tired of them, I haven't done it for my old boyfriend because he liked big boobs and he's gone, I don't want them anymore. Then just simply taking the implant out is perfectly fine. It's the difference if somebody has symptoms, then we want to get the capsule out. But if they're not having symptoms, not having a problem, a simple procedure to remove the implant and leave the capsule there is absolutely fine. The body will actually resorb that capsule and that scar tissue over time, just like it heals anything else. That scar tissue sort of goes away, and that capsule goes away.
So for the women who are concerned, they are going to take it out, or he recommends you get it taken out.
And en-bloc reception, absolutely.
So I just wanted to clarify, because some of them will hear that and think, well, he said.
No, that's, I'm talking about very simple. Somebody just doesn't want their implants anymore, we'll just take them out.
Right.
In that case, we can leave the implant. If there's any concern that the capsule is hard, or we're doing a true en-bloc resection, absolutely we're going to take all that capsule out.
All right, so I want to clarify that, because I know I was like, I could just picture all the. So anyway, any more last minute questions before we finish up today? Again, we'll revisit, and we're going to have some other specialists. I'm going to see some other doctors. Okay. So we're going to do Tip Talk Tuesday. And we're going to have other surgeons on. We're going to have scientists. We're going to have a variety. People who do the nutrition afterwards and stuff like that. We're going to just, kind of cover this just to give everybody some information. And thank you for being our test pilot. Absolutely. And so I appreciate it. And again, we'll have their websites in the comments below. And if you have any questions for them, let them know. And if you need to ask me anything, you can always private message me if you don't want to do it on the comment section. So thanks so much for joining us. I appreciate it.